Welcome back to the Movement Professional Podcast. So this week I'm joined by Dr. Asare Christian from owner of Aether Medicine in Wayne, Pennsylvania. Um, I've, I'll let Dr. Christian do his own intro, but I'll just say how I met him. I was listening to a podcast through the Curable app, which I think was Like Mind, Like Body. And typically the podcast is about chronic pain, and I just wanted to kind of get some more info and resources for my patients. And I heard a great conversation with this physician that I just found was doing very interesting things. And at the very end of the podcast, he said where his office was located, and I realized it was in Wayne, Pennsylvania, which is very close to my office. So I was like very excited to reach out to Dr. Christian and get to know him. And I since have, and I think it's been a great start of a professional relationship so far, and I hope it continues. But sorry, I'll have you give your background, your bio, what makes you unique, what makes your practice unique, because I certainly find it to be unique.
Yeah, well, thank you so much, Chris. And I really appreciate the opportunity to be here and to have this discussion. Just like you said, I also have a lot of respect for the work you do and how much science you put behind every aspect of your work in helping patients. And even beyond that, I also want to say thank you so much because I think when you came and learned about me, I was new in the area, and you did this post on Instagram. And that really got me connected to a whole bunch of other providers. So I really, have this gratitude for
Uh,
that connection and really appreciate even coming to see you myself personally to learn some things and how to deal with my shoulders and things like that. So thank you so much. But
Absolutely.
as Chris said, I'm a Asare Christian. I'm a physical medicine, board certified physical medicine rehab physician, and I'm the founder of a practice called Aether Medicine in Wayne. And we are an integrative and regenerative medicine practice that focus on cellular health as a way to solve pain, improve performance, and health span. And again, this has evolved, right? So when I started, there was a different way of, how do I solve problems? So my practice basically came to be because previous to this, I was the outpatient medical director at a rehab hospital in Allentown, Good Shepherd Rehab Hospital. Did that for 8 years, did neuro rehab, so MS, Parkinson's. All these patients have pain. And I end up treating pain. I didn't even want to be a pain doctor. And then through that experience, I recognized that majority of patients dealing with pain actually did not understand what pain was. And this subjective experience, if you don't understand it, how are you going to manage it? So I wanted to do something different from that standpoint. And what I also recognized through that experience was that when individuals were healthy, their outcomes from all the interventions that we're trying to explore for pain actually got better, because people will say, I've gone to physical therapy and I'm still in pain. They do that without dialing in nutrition or sleep. So people will do a few things. So I came to recognize the value of really fundamentally getting people healthy as a way to then introduce other therapies. Then everything else works a lot better. So
Absolutely.
my inception for this practice was to, how do we use health as a way to solve pain? So that has been the evolution. And the interesting things, which, I've talked about is, even though I've been a doctor for many, many years, I did not really know how to solve health. I
Yeah.
knew how to read MRIs, I knew how to do ultrasound-guided injections, I know how to prescribe medicines, but exercise, sleep, nutrition, managing stress, the things that actually make a huge difference, I have to relearn those things. So it's been such a blessing to be able to, have this opportunity to learn, and I'm still learning. And I'm glad that I got to come here and talk about, the things that we care about, solving pain for our
Absolutely.
patients. Yeah.
Absolutely. And yeah, when you mentioned, those things, kind of the integration of sleep, nutrition, physical activity. I heard you speak about that on that first podcast I heard, and it was something that I hadn't heard a lot of physicians talk about. It certainly was becoming a bigger part of what I was hearing within my continuing education in physical therapy, how we had to really practice from like this biopsychosocial model.
Absolutely.
But I felt like that there was a language barrier almost between physicians and therapists, or even other therapists, to be honest, because it wasn't part of our formal education. It was sort of like a budding field and discussion point. So I was really excited to hear, a physician talk about that, because a lot of times the physicians will be the gatekeeper, right? Like we're going to get referred,
Yeah.
from physicians. So that the language that our patients hear from physicians is really important. And I oftentimes it'll carry more clout than what we can say to them. So it was very exciting for me to hear that we're kind of speaking a similar language, but at the same time, we have to be offering different interventions and to see how we can sort of collaborate in that. And we're still kind of learning from that process. And hopefully that's what we're able to kind of put forward to the audience today is like, what can you do from a medical doctor's perspective to help chronic pain, but still like we're coming at it from this multifactorial approach. And then what could we do as on the physical therapy side of things, and how could we collaborate together? Because ultimately, like chronic pain is not simple. So it needs this collaborative approach, and these discussions I think are very important. So yeah, hopefully maybe this is one of a series that we do, because I think it's, what you offer is vast. So we don't want to overload it in just one session, but hopefully today we can kind of just touch the surface on what you offer from a chronic pain perspective, how you think about it. And I also just want to dive into what, in your vast experience, like what have you noticed that has really changed over the years? What are we doing well in the healthcare fields, and what still needs work, and kind of what you're excited about? So what would your assessment be at the current state of healthcare when it comes to chronic pain? Obviously, you changed your practice to, kind of fit with some things you didn't see going the right way in healthcare, but what would you say your status, or what's the status of healthcare at this point?
Yeah, well, thank you for that, and I'll get into that, but I really appreciate that opportunity to kind of, like you said, continue this conversation, and I also really have come to value that collaboration, speaking the same language to patients, and I kind of feel like because my learning about even pain, majority of the learning that really made a difference, the neuroscience of things actually came from physical therapists, right? Because so it sounds like in your space there was this education to really bring in the neuroscience of pain, which, as physicians, we did not really get into that. Some of us are getting into that, and really was not something that we were pushing forward.
Right.
And I saw the limitation of not really getting people to understand the neuroscience component, and recognizing that there's all of these lenses that we have to look through to correct the problem. And I have specific lenses and I have specific tools, and then recognizing that, like you talk about, pain is this multimodal process that it requires multimodal approach to really get it better. But getting back to the question of current assessment of pain, in my view, so I've been part of the International Association for the Study of Pain. This is this pain from a medical standpoint, and actually also from overall research, has been around for 50 years. And it sounds like, we've had clarity on what the definition of pain is. It's evolved a little bit, but the idea is that pain has this emotional sensory component. But in terms of how we treat pain for majority of the people in the country, specifically chronic pain, is just using the biomedical model, or a model that look at the definition of pain and just focus on the sensory component.
Right.
And basically the reason why, maybe that's what we do is the doctors can block that. We can give pharmacotherapy. We can do some of those things, but we know that blocking the pain signal alone doesn't really solve the pain, because when people have pain, there is multiple things going on. There's always, even if we're talking about nociplastic pain or brain generated pain, there's always biomechanical deficits. Muscles are not going to fire because people have chronic pain. So you also have to work on those things. So I think how we are treating pain, we've got a lot of science. The science has become clear. So there's been some good things in terms of from the neuroscience of things, and integrating all of this neuroaffective component into addressing pain, pushing more of the biopsychosocial. So integrating that. So that's a great thing. But I also feel like, despite all of those things, we still have majority of current practice in America that really is basically very biomedical, meaning we're just using medications, injections, surgeries as the only ways to solve pain. And we know that those models work for acute pain when people have hurt themselves, they have a herniation or they have a fracture. But when it comes to chronic pain, those models don't work. And what does that mean? That's why we still have 51.6 million Americans in chronic pain. So this is chronic pain, right? We're talking about pain that has gone on past 3 months. And we have about 17.6 million or so in high impact pain. So this is current data. Right. So despite some of this advancement, and we have, we can talk about some of the things we're doing here. So we have some options, but overall, there's many people who are still in chronic pain, and that has huge implications on overall healthcare expenditure. In fact, there is more Americans in pain than diabetes, heart disease, and cancer combined.
Right.
And it costs us about, 560 to 600 and something billion dollars to manage that type of pain. So there's been some movement in my assessment in terms of education. Patients are becoming more aware. Patients are becoming more open to exploring other modalities beyond the conventional biomedical model because they've tried it and it's not working. The medicine is not working. So that's a good thing. And overall, also integrating a lot of the neuropsych component to pain is all great. And then we have some regenerative therapies and some other therapies that can also help as well. But you have to put all of that together.
Right.
So
absolutely.
That's my sense of what's going on. Yeah.
Yeah, I've certainly seen change myself where there's a lot more education in appreciating like that the collaborative approach with other professionals, but also just like appreciating that pain it's just not in the orthopedic realm. So I know like what I tended to learn in school was that there was like pain equal damage. And I don't know that it was like illicit, like that's what was said, but it really felt that way, where like we were learning so much about how we could assess different damage in tissues, that's what we started to equate, is that pain was the same thing as something being structurally damaged. And I think that's still the narrative in a lot of places, but it's certainly changing. So like any type of continuing education stuff that I'll listen to, even online or in podcasts, there does tend to be much more of a component of trying to have like understand the patient's experience.
Yep.
And every experience is different as opposed to looking at a rotator cuff tear as a rotator cuff tear as a rotator cuff tear, right? So like if we define things based on the orthopedic diagnosis, it makes every individual look kind of the same. And it's just like, okay, they have the same type of structural problem. But we know that like you can have a structural issue and you can have no pain with that, but you certainly have varying degrees of presentation with the same or very similar type of structural presentation. So we have to like really understand like why is that so different? And if we try to just think about things from an orthopedic narrative standpoint, we're not going to get very far. We've done that for a while, and I think that it sort of you get stuck there. What I'm seeing though, and you probably see the same thing, is that patients are really still caught in that. It's almost easier as a professional to just ride with that narrative because that's where the patient is already a lot of times. And I don't know if that's because of the education that they've received over time, or just a lot of times like you get a pain, you look it up on WebMD, and like it's going to tend to talk about the structural implications more than the broad biopsychosocial implications. But it takes some doing to take away that thought of pain equals damage. And that's where it needs to be very collaborative, and we need time with people.
Absolutely. And like you talked about, in the 20th century, musculoskeletal pain was only looked through the lens of orthopedics, right?
Right.
It's a tendon, it's a ligament, it's any of that. But we know that is not all of it. So in fact, how I look at pain or the newer models of, integrating the whole biopsychosocial model, and even for me, is looking through the lens of, what we do as, physical medicine and rehabilitation professionals, right? Yeah. So we know that we focus on function. So even if there is a structural pathology or something there, what people care about is to be able to function, right? And then one of the things that I also recognize, this idea of, tissue damage and other things. So even through our lens as rehabilitation specialists, a patient comes to you and they have pain, they have some type of issue, and the pain is still there, but what they really care about is the function. So looking through that rehabilitation lens is really important to kind of get people to be functional. Mm-hmm. And then I also look through inflammatory, when we get into the cellular level of things, pain is a signal that is perpetuated by specific cells. And even in the brain where you're making an interpretation of the pain itself, there are cells. So right. Really also looking at what can we do to change that polarity of the cells to become healthy or to be able to not be so hyperactive is important. And then the very things we're talking about, the neuroaffective component, is super, super important. So I think integrating all of these things is important. But like you said, the other issue we have, I think, is also this idea of how healthcare is delivered. Because healthcare, how it's delivered determines how, I'm sorry, how healthcare is financed, because how healthcare is financed determines how healthcare is delivered.
Right.
Insurance is going to pay for MRIs, they're going to pay for injections, they're going to pay for surgeries, but they may not pay for you to do strengthening or nutrition or a psychologist or any of those things. So I
Right.
think all of those things are things that plays a part in moving us to a place of integrating all of these things. But the good thing is patients are recognizing that they need to do more, and
Right.
there is more opening discussions about this thing. So I'm hoping that this will continue to be the pace, and hopefully other policies when it comes to financing healthcare will also change to direct what we do, because right now we're not getting the results we are looking for.
Yeah. And I think like the idea of what can be imaged right now or what is most commonly imaged, it gives it an overly simplistic view of what like anatomy that we actually have internally. So you mentioned like the cellular level of how we can look at pain. And I like to think of also like just even the neurology of how we can look at like some of the receptors and all those things that we know exist within the body. They're just much harder to view,
Yeah.
right? So because they're harder to view, we don't tend to have an orthopedic model that takes their change into account as much as we have an orthopedic model of looking at bigger tissues like joints and muscles. And yeah, we can even look at, ligaments and even some inflammation within an area. But that starts to give like an overly simplistic view of like, if I have pain, it must be something within those bigger tissues, as opposed to looking at the cellular level, the neurology and receptor level, where that might be more dynamic in how those changes are made. And we if we were able to see them in real time, we might be
Yeah.
seeing changes that would be a lot more interesting, a lot more dynamic, but it would also give people maybe a little bit more hope that they don't just have arthritis that's just going to progressively worsen. That because we can look at some other tissues in the body that would
Mhm.
have a little bit more of a healing property, but like a more dynamic property where it's just like depends on what you're doing in any moment, how much inflammation's in your body, that it's always at flux. And I think that is part of the orthopedic narrative that's negative, is that we quickly get to the point where we'll look at some tissue and say, this is degenerating in a way that's only going to get worse, right? And that starts to kind
Yeah.
of get into people's
Yeah.
mentalities where it's like, well, what can I do about this? Like I have arthritis. They're telling me that like the arthritis isn't going to get better over
Bone on
time.
bone.
Then yeah, then now I'm in this state where it's like, what's the point anymore? The only thing I can really do is change the joint. And then there's no evidence that that's true, but I think that's also it's overly simplistic in how we look at the dynamic nature of the body and how it changes.
Yeah. And even just going, even at the cellular level, inflammation by itself does not mean pain, right? The
Right.
very things you're talking about, the tissue damage and all of those things. It's because, like we've been talking about, pain is this complex phenomena. So even when there's an inflammation, how the body or how your brain is going to interpret that pain signal is a function of what type of traumas you've had in your life. Where
Right.
did you grow up? In your household, were you allowed to express pain? So all of those things really changes the context of pain. And pain, as I'm getting to learn more about pain, like how complex it is,
Yeah.
where it's context specific, it's gender specific, it's environment
Mm-hmm.
specific. You can have an injury where you're in an environment where you're having so much fun, you didn't even think about it, right?
Right.
So even at the cellular level, when we understand these mechanisms, what goes on in the brain in terms of pain actually becoming an experience, I think is a little bit more deeper. And even the whole other thing that I think is also interesting is now we have all these sophistications to be able to kind of see in the brain, and there's all these
Mm-hmm.
areas in the brain that are involved. There's all these redundancies in the brain that are involved in interpreting pain. But even that, we also have to be cautious because we
Right.
don't want to get to the point where the same thing that we did with spine imaging, where we go, oh yeah, we see something here, and that's what's causing your pain.
Right.
We don't want to do that because the brain is more complex, and pain, I kind of feel like it's this complex mechanism because it is a protective mechanism. It's a way
Yes.
for us to survive. And we always have to be cautious about, how we are interpreting pain and how we are educating people. So I think this is all very, very interesting things. But the point that you're stressing, which I think needs to get across, is that pain does not equals tissue damage,
Absolutely.
because that's the thing. People have this fear. Anytime I have pain, something is wrong. Something must be wrong. And that is something that, people get into this state where that chemistry is now perpetuated or created
Right.
because now the nervous system has become hyper in trying to make sure that you are protected. even
Absolutely.
with that potential damage. Yeah.
Yeah, and I think we could make kind of like broad statements of like fundamentals where we look at like pain, it's not damage, but it's sort of it's a protective, mechanism. It's a danger signal, something along those lines. But as soon as we start to do that, we're sort of admitting that it's not one size fits all. That because everybody's danger signal, everybody's protective mechanism has to be different based on their life experience, based on what they find threatening,
Yeah.
right? And that's the terminology that I've tended over the course of the last couple of years. I've tried to veer my terminology more to what do you feel about the experience? Is it
Mm.
threatening to you in any moment? And but that changes even depending on the person. If I've been working with a person for 5 years, that'll be different on different days, right? So you get to know their threat response, but hopefully you're seeing that threat response diminishes a little bit. But that's so person dependent on any moment, right? So I think that's the thing where it's hard to mass produce
Yeah.
pain management,
It
and
is.
that goes very much against like pharmacology and things like that. Now that doesn't mean that it's not useful. It just means that it's part of the assessment process. Like everything that we're doing is part of the assessment process, but it's probably not going to be able to cure a
Mhm.
massive epidemic of pain just by looking at something that you're trying to mass produce. Like we will need process,
Yeah.
we will need clinical skills, we will need to like understand communication and work with people, right? All of this stuff is going to be part of helping people improve pain, and we're going to have to promote self-efficacy for the
Absolutely.
individual. Like if that's not being done, then I think we're barking up the wrong tree.
I love that because you brought up the self-efficacy. That is so important because it's this subjective experience that we're talking about, the perceived threat value, right? So, and I've heard where somebody described pain as, fear. It's a signal plus fear. And then
Right.
the signal plus fear, that perceived threat actually is what create pain. And
Mm-hmm.
that has been validated in, the pain reprocessing therapies. Pain is a subjective experience. Okay.
Yeah.
Take away the tissue damage, all of those things, whatever it is, it's a subjective experience. So the subject experiencing pain has to understand pain and know how to manage it. Okay. So I think that is something that, in all of these things, we just got to get people to get empowered to really understand that, okay, it's a signal and I can sit with the signal and I can give it a value of how bad things should be, and that actually influence the experience of pain. So self-efficacy, I'm so glad that you brought it up because we can do all of this science from a clinician provider standpoint. When it comes to pain, the patternistic approach doesn't work. If somebody
Right.
have diabetes and they come to me as a doctor, yeah, I can give them some strategies on what to eat, put them on some medicines or some things, and I can solve metabolic issues. But when
Mm-hmm.
it comes to pain, it's not like that. The person experiencing pain need to understand it themselves and become aware of the factors that actually keeps them in pain.
Absolutely. And I think it's so key to make education sort of a cornerstone. And that could be like a cheesy term, and sometimes it's a frustrating term for patients because that's
Yeah.
not what their perception is what they're getting from their healthcare professional. But over time, just allowing what we do as healthcare professionals be more of the teacher. And like one of the things I love about your office is it's set up like without any words being said to be a little bit of an educational experience because you have a room for sleep, you have a room for physical activity, you have a room for meditation, right? So you're demonstrating just by the way your office is set up that those four things are important.
Yep.
And that's just something like that stood out to me like the first time I was there. It's just like, oh, this is perfect because I think it's helpful to have that broad categorization of these four pillars that could be, collaborative in their approach to, having chronic pain be helped. But without that awareness, right? Like somebody might just have this, the blinders on. It's like, I want this pain to go away. Give
Mm-hmm.
me the thing that's simple, right?
Mm-hmm.
And it's not simple, and an understanding that we need to always be thinking about, let's say those four pillars, but probably some other things even on top of that, that
Absolutely.
it's going to be this constant education process. So I think that's something that you do really well with just even like the environment that you have set up there.
Absolutely. Environment plays a huge role in changing people's habits. So, intention with this practice is like the fundamentals, right? And like you said,
Hmm.
there's more social support.
Right.
that plays a part in how people experience pain and overall health. And the whole idea is that, even with this concept here of talking about the meditation, the exercise, the sleep, the nutrition, if you do that, not only is your pain going to get better, overall health, metabolic health will improve, cardiovascular health will improve, hormonal health will improve, microbiome health will improve. So
Absolutely.
it makes more sense. And like I said from the beginning, it just was so clear. And then these are things that we also kind of know, right? We go to graduate school and we get the fundamentals. We know that these things really needs to happen. And that has to be stressed. And like you said, when a patient is in front of you, you know those things and you have to kind of meet them where they are. And the idea, and for me, is like a lot of education. And then I would say, hey, okay, you have this problem. This is what I think is going on. And people are not so much interested in like nutrition or other
Right.
things when they're in pain, right?
Right.
So I say, yeah, I can do a blockade. I can block your, I can do some trigger points or some injections. It's just blocking the sensory component, right? It's not addressing any weakness that's there. It's not
Right.
addressing the underlying pathology if you have some biomechanics that's perpetuating the cycle. It's not
Right.
addressing the nutrition deficiencies or the bad nutrition that's still creating pro-inflammatory chemistry. It's not addressing the sleep you need potentially to also help you to bring down cortisol. So
Yeah.
it's really getting people to understand that, yes, there's a place for these things, but this is how far it's going to take you because these people will keep coming back. I need another
Absolutely.
injection. I need another injection. And
Yeah.
what are we doing? So I think it really becomes necessary to kind of educate people to understand the places for all of these therapies and what are they doing and the benefit and importance of integrating them at the right place at the right time to get people to get healthy.
Yeah, I think that's a really important point about like where everything fits in that there seems to be a movement sometimes to be I'm either like pro medicine or I'm
Yes.
anti-medicine. I'm
Yeah.
Eastern medicine or I'm Western medicine, right?
Yeah. Yeah.
And not appreciating that like that it's a collaborative, it should be a collaborative approach, but sometimes because of the lack of common language that we were talking about initially, it doesn't seem to be that for people. It's like, all right, I'm either gonna get surgery or I'm gonna do physical therapy, or I'm gonna, I'm gonna go the injection route or I'm gonna do the physical therapy route. And just appreciating that like these all can work together. And I'm
Yes.
a big proponent of, promoting medicine, especially when pain is acute, because I've learned from experience, like if something's really, really irritated, someone comes into the clinic, I'm much more likely to irritate somebody and make them worse, even if I feel very confident in what I'm doing. But I can't do that much early on. So calm that down. So whatever interventions calm things down quickly, that's going to be very valuable. But as we're starting to get into the sort of the more chronic pain realm, people have already done that and they're doing that over and over again. And now the problem is becoming you have to have some other strategy on top of
Absolutely.
that, right? And then that's where I think people then become more open to that conversation when things get a little bit more chronic. But I think I've seen a lot of people because I work with people now for 5-10 years
Mm.
where you start to get to see that they might be very anti-medicine. Like they're so pro coming in to see me as a therapist and a trainer that when medicine is actually the answer, they have to be talked into it a little bit. And I'm like, that's your simplest solution right there. I'll try to help you, but I may make you worse, where go take an oral steroid or whatever is recommended. But that can be the best thing in that moment. So to have those interventions, I think are super valuable. And it's interesting how I've almost seen sometimes the reverse from people is they're afraid to go down that, that path.
Yeah.
So they need that education too to see like this is to me where this would fit in. I'm not going to be the one to help you with that, but let me refer you to someone, do that as quickly as possible, and then hopefully we'll be able to do more together.
Yeah, and that's super, super important because as you pointed out, all of these interventions has a place, right? So really and then patients have had experiences. So I see why patients don't want to try any of these things
Right.
because nobody explained to them, they had side effect, it wasn't done. I tried something, it didn't work. Why didn't it work? Because they
Right.
just gave you medicine and they didn't send you to physical therapy and they didn't talk to you about the fact that you're not sleeping. So all those interventions has a place and is really trying to I think providers need to be aware of those things and seeing the limitations of the things that we have because it doesn't work for everybody, right?
Right.
Some people will do well with medicine, some people will not. But I think as providers or clinicians in this space dealing with pain, we need to be all open to all of these modalities that potentially can help patients get better, right? What else can we do to augment the process? Maybe they're moving so slow in therapy. Maybe can they do a trigger point so then therapy can go faster?
Right.
Can we manage the pain a little bit better so they can do a little bit more rehab?
Right.
And the education piece is also very, very important because even the medicines that we use, first of all, there are side effects. And then there's also stigma, right? There's a place
Right.
for opioids and all of these other things now that we use them. But even getting patients to feel comfortable sometimes to do those things, even though it's going to help them, sometimes they don't want to do it. So
Right.
the education for me is I talk to them since, I'm rehab, functional. I tell them, okay, does the medicine allow you to become functional? Does it help you to do certain things
Right.
that you couldn't do before? If it does, then let's use it for that purpose. So I think that education and intention behind why we are using pharmacotherapy also need to be really become relevant in education patients because otherwise, they take it, they don't know why they're taking it, they feel
Yeah.
bad about it, they have some side effect. And again, we also know that, all the thoughts behind, if you're taking something and you already know it's not going to help you or you're
Right.
worried about side effect, then it's not going to work. So that education from providers who are prescribing these medicines and the place and how long duration, all of that is really, really important.
Absolutely. And that's where I think that the collaborative experience is super important there, right? So to say, all right, it doesn't make you functional to have somebody then that can specify function
Yeah.
better, like for, in supervise the functional process. So
Mhm.
if I have given somebody four things that they like would be useful functional markers for them and say like this is where you are now, but if you were here, then would you agree that you're going to be in a better state and that's going to be your quality of life will be improved? So having those assessments of what function means, it's because for a lot of people it's just I don't want to hurt in my daily life.
Yeah.
But I think sometimes we have to be more objective with where are you in
Yes.
that process, right? And that's something I've noticed was even a weakness within the physical therapy realm is we were not great at breaking down the functional things that people want to get back to and saying like, where are you in this process now? It's either I can do it pain free or I can't, as opposed to can we deconstruct the functional thing that you want to get back to and actually see like where are you on this
Mm.
path? And then it becomes much more obvious that okay, I took some type of medical intervention. I'm farther on this path now, right? Because a lot of times the pain doesn't go away 100%. And I don't
Yeah.
even think, in the broad spectrum of your life, like you want pain. Pain that has a purpose. It's very important. So we need to be able to utilize pain. And I think a lot of times the longer you're in pain for, it becomes this thing you're trying to avoid at all costs, which is an impossible dream in many ways. So it becomes how do we utilize pain, but also see it in a continuum being moved
Yeah.
farther down that continuum where it takes more to bring it on. And if we don't have that objective process for breaking down the thing that is meaningful to the patient, then I think it gets lost, right? Like, yeah, the pain's better when you have an intervention, but it comes back because there was never an assessment of, where you were in the
Yeah.
process and what we can do to kind of move you along that process.
Yep, absolutely. The functional piece is super, super important. And even for me as a rehab physician, I kind of feel like physicians don't do it. Maybe some people do, but I think this is where having an excellent physical therapist who can kind of walk them through that process that you're describing makes a huge difference because it's all self-validating. Patients
Yeah.
they need to know that they're actually making progress. Sometimes, like you said, they focus so much on the pain signal itself. And then you go, hey, you're actually able to do this now. You actually
Right.
came here and this is where you are. So even though the pain is still there, you are still making functional progress. And then getting people to also focus on those things actually we know even help with pain. Because if they're always focusing on the pain intensity, then we know that the pain is going to go up. So that's
Yeah,
really important. Yeah.
absolutely. And I think what's important in that, at least from the movement side of things, the physical activity side of things, is that we don't make the intervention all about the person's pain. Right.
Yeah.
And that's certainly something that it's hard to do when you're
Love
actually
that.
in a physical therapy clinic. And you talked about like the financing of healthcare will kind of dictate how healthcare is delivered.
Hmm.
Well, if it's all about what gets covered, a lot of
Yeah.
times you're not allowed to like treat the whole body. We have to be
Yeah.
very careful about how we write. So you take yourself out of the insurance realm, it sort of changes the way you look at treatment where what makes sense after a while is like let's do more of what you can do as opposed to focus 100% on what you can't do, right? Like you'll know pretty quickly what you can't do, And you can't do much with that because you'll irritate it. You could do a little bit with it at a time, short bouts frequently to try to build up what you can't do, but celebrate what you can do. And what you start to find is patients become a lot more patient in the
Yeah.
process to get better because they're working on things that are good for their health and their movement. And then that also helps the systemic processes of circulation and lymphatic
Yes.
drain and all the things that we know. The body is a system of systems. So by working in things that people feel safe with, they're getting more time to allow that to heal, but to work on it as they see fit. But then before you know it, it's like, okay, how is that the shoulder? Right? Well, it moves a lot better. It's still painful, but it moves a lot better. But we were taking all this time. We weren't just wasting our time just waiting for this to be perfect. We've been doing a lot of stuff to build up, the body in many other ways. So that just, in my experience, becomes so much more valuable to the client and the patient instead of having it just be like, okay, we're only going to treat that joint that's in pain.
And that's very unfortunate that we have a system where that becomes the issue. I send somebody to physical therapy, they have back issues, they have hip issues, and I'll have to switch the script to something else before they can treat the
Right.
other component. And it's one system, right?
Right.
And as you know very well, the hip joint will implicate the knee and the ankle and everything else. It's one system. So that approach of really looking at the whole person and integrating is super important, and that limitation we see with insurance company. But I think patients are becoming more educated and see the value because
Right.
they recognize that when I went in with my insurance, all they could do was my knee, and it's also provider specific.
Yeah.
So I think having providers like yourself who are able to kind of step out and really take a look at the whole person and say what do we need to do for this person to get them better,
Right.
instead of like what does insurance allow me to do, which is quite limiting, and I know it's very frustrating for a lot of providers.
Sure. All right. I think that's a good discussion about like, what we're sort of agreeing on is what we see is like needs a little bit of improvement, but
Yeah.
also, there's definitely been improvement in my career, and I'm sure in yours, and I think we're moving in the right direction. Um, Specifically, what are some of the things that you're excited about? I know you got your finger on the pulse of progression in healthcare. So, what are you excited about? What have you been learning about that you think is really going to maybe move the needle with some of the chronic pain issues we're seeing in the country?
Yeah, so I think one is there is this whole interest in really understanding the systems that perpetuate pain, right?
Hmm.
So it used to be like we've been talking about through the lens of orthopedics, and now we have all this literature that is validating what's going on in the microbiome and how that plays a
Hmm.
part in turning astrocytes or microglia cells to become bad actors, or
Yes.
turning on neuropathic pain. So a lot of literature is showing up in importance of the microbiome, short chain fatty acid, all of these things, mediators that actually can modulate what we do with pain. So then we're not just focusing on, okay, you have to use, prostaglandins or NSAIDs or whatever. So we
Right.
can even use simple things that can help solve that. We've come to appreciate the importance of the, HPA axis, right? The stress response and how cortisol influence pain, stress, autoimmune disease will get turned on from specific stresses. So all of those cellular understandings are becoming very clear, and it's changing how we're looking to solve pain. And then we also have regenerative therapies, which is great for healing specific MSK, musculoskeletal issue, autoimmune issues, but all of those therapies, especially when it comes to the regenerative things, if in a person who has chronic pain, there always has to be a lot more than just those things.
Yeah.
And when somebody has an individual acute stuff, regenerative things works really well. So it's really, I kind of feel like the space is opening up for looking at how do we get to the root cause of it, right?
Right.
If it's an autoimmune, where is it starting? Can we do something about the cells in the gut that's causing this problem? Can we do something about specific things that are influencing somebody's state of degenerating, right? So
Hmm.
senescence. As people get older, we know that there's all of these other things that are changing that can predispose to pain or predispose to degenerative things that can implicate biomechanics and potentially pain. So we're kind of thinking a little bit ahead in terms of how do we solve pain from the root level. So even for me personally, I've come into this space of really understanding aging and aging science and how we're seeing aging as a disease, because risk factor for any disease, majority of the disease that we see is aging. Right. So even when I'm treating osteoarthritis, I am thinking about, yes, there is senescence, there's chondrosenescence in the cartilage, right? We're talking about bone on bone. There is metalloproteases, there is enzymes that are breaking down, there is degeneration, there is increased osteoclast activity in the bone marrow itself. So when I'm trying to treat pain or osteoarthritis, if it's a young person, yeah, those people can do very well, with some therapy and some, blockade of whatever it is, or regenerative therapies. But if somebody's older, I have to work on mitochondrial health. I have to work on decreasing, focus on the osteoclast activity. So I think our understanding of all of this disease states and getting specific through the science of aging is also very exciting. And then beyond that, we have, AI and other technologies that can, influence digital health. So there's even, 3D things that people can explore for pain. So I think all of those things are exciting, but it becomes really trying to figure out, how do we harness all of these therapies, all of this knowledge, and package it in a way that we can get it to be like, okay, this person, this therapies is where you need to start from. And I think that takes expertise, that takes open-minded. And then also recognizing that beyond all of these therapies that we're doing, which a lot of them actually tend to be more passive, people still need active modalities. So I look at all these interventions in a class of active, passive, right? I can do medicines, I can do injections, it's a passive modality. Even if I solve, even if I solve your microbiome, it's a passive modality. People still need to strengthen muscles, people need to change, put stress on the system to really get us to a place where pain is less likely to come back. So I'm excited about all of those things. And I think, there is more to come, especially now with AI and in terms of, cranking out research and what else we can do. Yeah.
Yeah, I think what's like you mentioned the immune system and the microbiome. I think those two things to me are like very fascinating topics. And then combining like the technology coming up, I think what is key is trying to get better and better monitoring services, or like to be able to monitor what's going on in real time, right? Like, so ultimately, like we have to have some type of biomarker when we look at systems, right? So I think like the immune system is often underestimated when we talk about pain, and also just even things that we look at like a training stimulus. Like when we're trying to actually, we're not necessarily in pain, but we feel like the pain of post-exercise, we'll have different ways that we define that. We'll say, oh, it's muscle soreness and things like that. But is it? You know what I mean? So I think a lot of that has to do with changes, like how your immune system responds to a stress, right? Like there's a physical stress happening. You're purposely giving yourself that physical stress. So there's got to be some type of immune response to that. And if that immune response is heightened, or if it's not enough, that could be problematic. So having over time better ways to monitor that immune response in a real-time manner would be awesome. I don't even know if that's possible, but I think that's one of the things that we've seen, I think, change in a good way. We have a lot more ways to monitor things in real time. Like we could look at our heart rate and see different ways of the heart rate zones changing. We could look at heart rate variability, which is, a proxy for looking at our stress response in different moments. And I think that technology is certainly getting better. We can look at different things with sleep, and that technology is certainly getting better. So I think the better that technology gets, the more reliable it gets, the more that the individual can be the one monitoring it, that really builds self-efficacy in a very objective way, right? And it sort of gamifies things. I know for me, it makes the process of health more entertaining. It really does. Like I always exercise sort of just for the sake of like, it feels good to do it. I used to be an athlete, but when I actually started using like a heart rate monitor combined with like heart rate variability, the idea of like cardiovascular exercise became a lot more entertaining because it became more personal to me. Like I didn't have to work harder than I needed to, but I knew like also what I was capable of because I'm looking at my own heart rate in the moment change and things like that. So I think the more metrics we're able to get for more systems of the body, like, so it's not like a guessing game and sort of a theory hypothesis game, but like we're looking at it as like, okay, this stimulus was a little too much for you. Look at some of these immune markers. And I think the same thing with the microbiome. Like I could say anecdotally, when I take any type of like fermented food, the right type of fermented food, like my whole affect changes. Like I feel amazing. It's like
Mm.
I used to drink alcohol like 15 years ago, and I feel almost like pre-drunk when I get the right fermented food.
Wow.
Like it makes my belly feel good, my brain feel good. I get more social, but I could absolutely see like pain relieving benefits from it. But again, that's very anecdotal. So if it was, what do we know that the things that we're putting in our body are making that change? I think that's what I'm hoping things get better at. I think it's a difficult thing
Yeah.
to study. As I've certainly heard that, but I think that could be very promising. Is the more we're able to look at some of that stuff in real time, have better biomarkers for it. I think that really starts to move the needle. And as opposed to, again, being all this orthopedic narrative, we're starting to look at all the systems in the body, and we have more direct ways of seeing progress, and we can then adjust nutrition, we can adjust
Yep.
different things. And then, I think if the patient is able to see change in a more direct way, that becomes more motivating, right? It doesn't feel like this helpless effort.
Yeah, and then the biomarkers. So that's a great thing you're talking about. So even for immune, like you talk about immune function. So there's some specific functional medicine texting. There's one called CytoDX that looks up markers of pro-inflammatory and inflammatory cytokines, and this is very good for teasing out autoimmune issues, other things. But again, it becomes these things are always happening, right?
Right.
There are spikes of inflammatory cytokines with certain exposure in the environment that your body is always kind of sensing and reproducing. So getting to a place where we can actually, like you said, being able to get more specific and be able to modulate certain things and get that feedback will definitely help. When it comes to the microbiome, there's a lot of work done on like looking at osteoarthritis, neuropathic pain. And again, a lot of these studies to, like you're talking about pathways, we understand them. And a lot of them are in animal studies. So there's, it takes a while for, a drug to be made to address this. So the people in the space of integrative medicine, there's the supplements and other things that some of them do have some good response. And I've got really amazing response with managing pain, which I kind of knew by just checking the microbiome. So I do a
Mm.
GI mapping test, and it's just blown me away because I've actually had patients where I thought their pain was nociplastic pain. Of course, there was a nociplastic component. It was like
Mm.
pain generated. We couldn't figure it out. There's just, epigastric pain, chest pain that comes on with stress and other things like that, which, I understood that those stresses were what was, what will like perpetuate the pain, but there was something underlying that kept the pain there. And it was some infection in their gut that we pick
Mm.
up with the GI mapping test. And once you treated that, their migraine actually went away.
Mm.
And this was a patient that I'm trying to get insurance to approve, specific medicine for them that was safe for them. They wouldn't do it. And we did this test. We figure out, we pleated some stuff in the microbiome and no more migraines.
Love it.
So, and I've seen so many in so many things. So the microbiome has become this place that I'm so blown away as to, which I kind of knew. I mean,
Right, right.
so yeah, so this is all really exciting, and we're really changing the focus and going beyond just like, okay, MRI of your spine and that's it.
Right.
Yeah.
What interventions do you tend to go to when you have, something where the microbiome is the thing you're targeting?
Yeah, so one, it becomes what we see. So one, trying to figure out if people have dysbiosis, right? They have an overgrowth of something that's not supposed to be there.
Hmm.
And why is that happening? Sometimes it could be a function of medication. They're taking specific medicines that are messing up the microbiome. A lot of people are on H2 blockades or proton pump inhibitors that are supposed to be used for a short time, but people take this since for a long time, and that suppress their acid production, and that can implicate how specific bugs or microbes are growing. And then because you have that, other bad opportunistic bacteria could be growing. So it becomes, address that. You can give probiotics or certain type of introduce certain type of strains that will help balance that system.
Hmm.
Sometimes it could be a function of intestinal markers where they're not digesting proteins very well, right? So they may need some pancreatic enzyme support or sometimes gallbladder support. but it all comes to why is that happening? And sometimes it could be a function of what they're eating. So it's really also getting people to really understand these are the things that is actually creating this problem. Let's not just give you protonics. If you eat this food and it always causes reflux or something for you, it's telling you something, right? We have to solve the problem. And then sometimes people may have, specific bacteria or specific, and I'm really shocked how much like there's all these different bugs that people are carrying around either because they drink from other places. We have all this fecal oral contamination that happens. And a lot of people will have H. pylori, which is very common that I've seen. And once you treat that, a lot of things get better. So it depends what is really going on. Sometimes there's gut permeability issues or leaky gut, where there's elevation in zonulin. And by addressing that with the specific, probiotics, echinacea, makes mucosa, produce mucus to protect the lining. So it gives you so much information, and it's normally what people are putting into their body. There might be some gluten sensitivity that you have to kind of monitor, address that. So it's very helpful to get a broader picture of what's going on, and it becomes where do you solve the problem so the body can work itself out. And a lot of times you don't have to fix everything. You just have to fix one thing. You have to know it, fix one thing, because the microbiome is actually always changing. Every 4 days, there's something new going on, right? So being aware of all of those things, and then the person in front of you is what we want to kind of put together, because it's not just the biomarkers. Sometimes the biomarkers are there and people don't have any issues. So again, really kind of connecting all of this holistic integrative thing helps to figure out how to address those problems.
Yeah, and I think,
but I'm a big believer of the microbiome.
Yeah, absolutely. And I think like one of the issues that people run into nowadays is like, again, if you're thinking of it as a simple thing, right? It's a dynamic thing, and that, all right, well, I'm taking a probiotic, so I must be good, right? Like I'm already covered there, right? As opposed to it being a clinical assessment process, which is what you're describing. So I think that's important for people to hear, is like you can't just take probiotics. For one, you don't know if they're targeting what you're looking to do. If they're actually, if you're just taking something over the counter, it's very unlikely that it'll be absorbed in the way you want to, right? So it's a clinical assessment process that may include probiotics. And to me, I would imagine that you have a better understanding of like the higher quality ones, like being a physician, and probably have access to different things than just someone going to and getting something over the counter.
People should not be not everybody should be taking probiotics, and you should not take it for that long. Okay, so people take these things, and I ask them, how long have you been on it? And you don't even know what it is, right? So, and then they talk about, the number of millions of whatever. It does, the body is always changing. So you have to, and if you put something, it's going to adapt. And you don't need, it's not about having too much of this specific strain in your stomach. It's all about balance. It's all about balance, okay? So when you're sick or something else is going on, your body going to adapt a little bit. You're going to need a little bit more of this. So really kind of hitting the body with the same signal all the time is not a good way to treat people. And definitely when it comes to probiotic, people are doing way too much, and the literature kind of support it. And I've seen that, it's not necessary. Like you talk about, if we can get people to eat fermented food, if we can get people to increase their fiber intake, that is what the colonocytes needs, or short chain fatty acid. If you can get those things in, the body and the cells will digest it, and then it will help support the microbiome. It will reset it. So I think it's really important for people to really pay attention to those things, because a lot of times I think it's doing more harm than good.
Absolutely. I think that's an important point. I think that's another broad principle too, like that your body will adapt to anything that you do for long enough. So, and I've certainly noticed that with supplementation, where like there's some things that like you get an acute effect when it's new to your body. Right? And sometimes that acute effect is negative, or you might get GI distress or side effects or things like that. But a lot of times it can, if it's meant to be positive, it can be positive. It's like, so there's some things that make your brain feel like they work better. You do the exact same thing long enough, you won't get that same response, right? And then it becomes like, oh, I got to take more of it to try to seek out that same response. But I think a lot of times when you don't even get that acute response, you're just sort of like on faith, assuming that, you got everything covered because you're taking a supplement daily. Well, definitely know that maybe that thing wasn't working in the first place, but if it did, your body is adapting to it, right? Like, so probably doesn't have the effect that that it, even if it did it early on, and that it's not going to continue to have that effect going forward. So I think that's an important thing to talk about, because the way that we think about supplements in in the country, probably in the world right now, is just like, it's sort of like brushing your teeth, right? Like, I'm just gonna
Yeah.
set it and forget it, and hopefully I'm good. But I think there needs to be a clinical process to it.
People need guidance on that, because one of the things I also see, because all these things that we put in our body from, the supplements and all of these things, they have to get metabolized by the liver. A lot of times we don't know what it's doing, right? And even when and people have good intentions. I take supplement myself,
Right.
but you have to really pay attention to what you're doing. And this is not things that is, getting validated or getting reviewed by FDA or safety things ongoing. So people create their own product, they put their own science behind it, and they get put out there. It
Right.
doesn't mean that the science is not right. It doesn't mean that they have bad intentions, but people need to understand that this is not something that you want to, you want to try it out. And this is what I tell my patients, like, take it for a little bit, back away from it, see how you feel. And it depends what you're using,
Right.
right?
Right.
But people take supplement for 10 years, for 5
Right.
years. I've been taking it for any, so I always kind of go on the side of, okay, let's take a break from this. We don't know how this is affecting your kidney, your liver, and is it even getting to the right place, right? You're
Right.
taking this
Right.
thing and you're hoping that whatever ingredient in it, if it is the correct ingredient, is getting to the right place. And we also have to worry about toxins
Yeah.
in some of these things. So it's a space that it needs a lot more guidance with navigating. And I'm very, conservative when it comes to that. There are certain things that I use that helps a lot of people, and I tend to get people off. Sometimes people don't even want to get off, right?
Right.
Because, oh yeah, my pain is so bad. I was like, well, let's back away from it and see how you
Right.
do. Yeah.
Beautiful. Love it. I think we covered a lot today. I think it was a great conversation. Hopefully you feel the same. But
Yes, absolutely.
I'd love to maybe do a series here where, like, I know you have a lot of expertise in, we can call it the anti-aging realm, and some of the things along those lines, where I think
Yeah.
are really important, and will probably connect a little bit to our discussion on, chronic pain. But I'd love to kind of pick your brain on some of the interventions you're doing, but maybe we'll save that for another podcast.
That would be wonderful. And I'm always happy to talk. I'm also learning from you. So this is really wonderful. Yeah, so this is great. Yes.
Absolutely. All right. Well, I will see you next time, and I appreciate you coming on.
Thank you so much for having me, man. Looking forward to having more discussions.
Absolutely.